I'm greatly appreciative of Kevin and HealthWatch USA's efforts with this meeting, and it's been critical in my case to give me a platform to communicate what I think is a very significant problem with hip replacement, which is one of the more commonly performed operations in the United States. There are likely 4 to 5 million Americans with hip replacements, most of which are at risk for this problem. And this audience in this room is about the only people in the nation who are presently aware of that at this time. So it is a very large problem. I'm big on disclosures because I think the reason that we're in this pickle with hip replacements is these devices have been relentlessly changed and promoted by industry in conjunction with rock star orthopedic surgeons who have profited enormously by it. And when I've been to the meetings, and in fact part of the reason I got a hip that made me sick was a result of their influence on me when I go to meetings. And the common thread when you go to American Academy of Orthopedic Surgeons sponsored CME event is there'll be a panel of rock star surgeons at the front of the room, not a single piker in the bunch. I mean, these are all individuals paid on the order of millions of dollars by industry to develop these devices. And a lot of times their disclosure is, well, yes, I do collaborate with industry in development of these devices, but I don't believe it has anything to really relate to this talk that I'm giving today about complications. And I think this lack of transparency in the role of orthopedic surgeons in the United States of America in developing these devices in conjunction with industry is the primary reason that we are in this problem today. So I'm certainly not the first person who's been poisoned by their hip replacement. I'm the first person reported in the literature to be poisoned by a marketed hip replacement that's what we call a primary hip replacement, or one that was done the first time. Serendipitously, I was implanted with a DePuy ASR metal-on-metal hip, which at the time I had my surgery was a very popular implant. I believed it had been well vetted and supported. It's in this class of metal-on-metal hip replacement, which has received a lot of publicity. About 1 million were implanted in the United States. I think what people need to realize, of that 1 million Americans, only a fraction of those implants have been recalled, and that the only metal-on-metal implant that was recalled from the market was the implant that I was implanted with, and that is only about 10%. The other 900,000 patients out there are generally unaware that they have an at-risk implant, and they're generally not monitored. So not only was I the first reported case, I wrote the case report. And the case report included the only patient that I implanted with an ASR. So as far as my personal experience, the adverse effects of the metal-on-metal hip was 100%. Myself and the one patient I placed an implant in. Certainly the metal-on-metal hips are a high-risk category for the problems I'm going to talk about today, but they are not the only hips that are at risk. And this is the compelling information that I have learned over the past several years, is the majority of the 5 million Americans who have been implanted with hip replacements over the past 20 years are at risk for this problem. The mechanism is different, and I'll get into that. One of the things that keeps me coming here every year is the fact, as a surgeon, I have implanted at-risk implants into about 1,000 patients. And I am just beginning to to bring those, serendipitously when those patients come into my office for follow-up or they're developing arthritis of their other hip or another joint, I'm talking to these patients about potential toxicity, and I'm measuring their blood or their urine cobalt. And this is the astounding thing to me. About 10% of my patients that are coming in for routine follow-up, none of these devices are known by the public or most orthopedic surgeons to be at risk for this problem. 10% of my follow-up patients are peeing cobalt or have elevated cobalt in their blood. So if you look, this is StephenTower in Anchorage, Alaska, and I'm not a rock star surgeon. I'm not a high volume surgeon. So if I am observing this in my own particular practice, one can just imagine how large of a problem this is nationwide. And my other disclosure is I am a member of Health Watch USA. So the talks I've given here have been an evolution over the past 3 years, starting pretty much exclusively with the metal on metals 3 years ago. Then last year, as I was aware that this same problem could occur in commonly implanted metal on plastic hips, which have been the gold standard commonly used hips in the United States due to a different mechanism of corrosion. Last year I concentrated more on the corrosion issues. What I've learned over the past year is not only information about the frequency in which the corrosion problems are occurring in the patients that I've placed hips and the referral cases I get from outside my practice in the Alaskan community, but we now have a means of actually imaging the pathologic changes in the brain. And of all the varied things that cobalt can muck with in the human body, certainly what most affected me when I experienced cobaltism, which is systemic cobalt poisoning, the encephalopathic symptoms were what most affected me and most worried me, certainly. And certainly within my own practice, I'm now able to recognize these patients often, usually before I ever check their cobalt level. And for those in the audience that practice adult medicine, when you look at the problems these patients have, they say, well, this is most of my waiting room. Cognitive decline is a common problem in an aging population. Patients commonly come to their primary provider noting fatigue. Mood disorders are incredibly common in the American population, even more common in an aging population. And fine motor incoordination and tremor is almost expected among patients and family as people age. The difference is the severity of the problems and the frequency they occur, and how often they occur together in the patients that are exposed to cobalt. The imaging, and again, a lot of my story is serendipitous. Downstairs from my office, there's an imaging center with a remarkable radiologist who's interested in nuke med. And a lot of people find my story to be interesting, and I bend a lot of my fellow physicians' ears with my story. And when I was talking to Dr. Bridges about what I was finding, he says, gee, Steve, we ought to do an FDG PET brain scan on one of these patients. What you're telling me is the early symptoms these patients have are primarily encephalopathic, and FDG PET brain scans look focally at brain metabolism and have been one of the really productive imaging studies to diagnose and sort out patients with cognitive decline. And there's very typical patterns in the brain for the various dementias. So we sent the first patient, and the brain scan was remarkable in the degree of hypometabolism in certain areas of the brain and the brain in general, and the pattern was fundamentally different than that was described for Alzheimer's, frontal temporal dementia, Lewy body dementia. So once we recognized that, we started in my practice as I started seeing more and more of these patients presenting with these complaints and elevated cobalt levels, I kept on sending more patients to Dr. Bridges. And this is a synopsis of our first 8 patients. We're now up to 15. And this has been over a period of about 18 months. And what you have to understand is these are patients who have walked into my office. I haven't called them in. So this is not a systematic study of my patient population. These are just patients that have come in through routine follow-up. And you can see, as you would expect in the hip replacement population, it seems to be equally represented among gender. These patients are generally apparently getting into trouble 8 to 10 years on average after their hip was placed. And they have a significant latency after the hip replacement before they start to notice these problems. And there's a very significant range in severity of symptoms and how disabling the problem appears to be. And their average, these are all corrosion cases. These are not metal on metal hips. These are metal on plastic hips. They're not recognized to be a problem in the orthopedic community or in any medical communities. Yet their blood cobalt level is 6 parts per billion, which is about 30 times the level of most people sitting in the room who do not have Chrome-Cobalt implanted implants. It's 6 times above the biologic exposure threshold, which is the level for suspected safe cobalt exposure used in industry. But that number is comparatively low when you look at the metal levels that we were seeing in the metal on metal patients that were experiencing systemic cobalt poisoning from their implants or cobaltism. So this is what the FDG PET brain scans looks like consistently among our 15 patients. Blue is bad. Blue represents severe hypometabolism. The ice blue that you see in these images, I think, is -3 standard deviations of gender and age-matched normals. And even though some of these scans show hypermetabolic areas of the brain, that's artifactual. These brains are generally hypometabolic, but there's internal references in the technology which would make an area of average brain metabolism appear hot for these patients. But these are profound findings on imaging. These patients' scans actually look worse than the patients do. And this is something about FDG PET brain scans. When we use this imaging for patients with Alzheimer's disease, we will see changes on FDG PET brain scan before patients have significant clinical symptoms of Alzheimer's. So it tends to be a leading indicator, which I think will make it very valuable in further delineating the cobalt problems. So my experience has been a sequential with my own personal experience and the recalled ASR metal on metal implant. The second step was realizing that it wasn't just the ASR metal on metal implant that was at risk, that all metal on metal implants were at risk. And in Alaska, because of my experience, we were hyper aware of the metal on metal issues. So I think in Alaska, more of these patients have come to revision surgery and remediation than in other areas of the country. So in Alaska, probably about half of our metal on metal hips have been revised. These patients have very high cobalt levels, or around 40 parts per billion, about 10 times the level of these new corrosion cases. And this is a fundamental point, and I think a problematic one for recognizing the extent of the corrosion problem is the cobalt produced by corrosion is an order of magnitude more toxic. So if you have a patient exposed to 4 parts per billion from corrosion, they're likely to have the same sort of pathophysiology and symptoms as a metal on metal patient that has a level of 40. And this is not recognized among even the providers that are familiar with cobalt poisoning from hip replacement. Disease levels are lower than one would expect somebody to have systemic toxicity from a metal-on-metal implant. But the thing about our metal-on-metal series, when I was reviewing these cases, these hips were all revised because of problems at the hip. And I was noting incidentally that a third of these patients were giving a good story for the encephalopathy. And this is one of our cases, a rather extreme one. This is a published case report of a pilot, owner of an air service, who developed debilitating Parkinsonism requiring deep brain stimulator and maximal drug therapy, 2 metal-on-metal hips, very elevated cobalt levels. He didn't have symptoms at the hip until about a year after his extreme Parkinson's developed. The hips were both revised, his cobalt levels normalized, and his Parkinson's all but went away. He's been able to turn off his deep brain stimulator and he's off drugs. But this is very significant illness for this man who lost his vocation and lost his business. This strikes home to the nurses in the audience. This was a young woman who had acetabular dysplasia, received a metal-on-metal hip, a non-recalled device, at an early age. And although she would see the surgeon in the halls of the hospital and they had conversations about how much she liked her hip, and even though she had a metal-on-metal hip and we were beginning to become aware that cobalt poisoning was possible with metal-on-metal hips, their conversations always related to how happy she was with her artificial hip, as she had had disabling arthritis. It took her a couple of years to develop cognitive decline in terms of she had been a voracious reader. She didn't completely lose her ability to read, but her comprehension went way down. She was getting forgetful to the point she was concerned about her quality of service she was providing to patients, and she was developing a tremor that made it difficult for her to start IVs. She finally came into the office, incidentally, because of vocational-related back injury. One of the PAs in my office was hyper-aware of this problem, checked her blood cobalt. At this time, she was actually developing some crepitation at the hip, but no pain or other symptoms. Long story short, her blood cobalt level was found to be very high. She was revised, and her systemic toxicity resolved. So the next thing we found in Alaska was another recalled implant, but not a metal-on-metal implant. This was a metal-on-plastic implant where the neck was a separate piece of Chrome-Cobalt. That second modular junction was quite prone to corrosion. Since this implant was recalled, doctors were notified to contact the patients, come in and have their cobalt levels monitored. The concern was not systemic toxicity, but reactions at the hip to the corrosive debris that could damage the tissues around the hip. A process is commonly termed as pseudotumors, because a lot of times there's swelling or fluid collections about the hip. Another probably more accurate term is adverse reaction to metallic debris, or ARMD. But I was struck by this series because we had about the same number of patients. The latency to symptoms was about the same. And again, about 1/3 of the patients had encephalopathic symptoms on review, but their blood cobalt levels were an order of magnitude less than the metal-on-metal patients. And this is a fundamental point that the cobalt produced by corrosion is biologically more toxic than the particulates produced by the metal-on-metal wear mechanism. So this is an example of one of our toxic patients with a recalled rejuvenate implant, somewhat older but quite well woman, who over a period of 2 years after implantation developed a whole slew of medical issues, largely being constitutional in nature, fatigue and weight loss. She also developed cobalt cardiomyopathy, which is a common comorbidity with our encephalopathic patients, but generally the cobalt cardiomyopathy tends to be asymptomatic. And generally we pick it up on echocardiogram as a stiffening of the heart, which can eventually progress to systolic symptomatic heart failure. Same story, her cobalt level was quite high for a corrosion case at 11 parts per billion. So probably if she had been a metal on metal patient, she was behaving like a patient with a cobalt level greater than 100. And again, the same story, the implant was revised. It only was revised once she developed a significant problem at the hip. But then after her revision surgery over a period of years, her encephalopathic symptoms and her cobalt cardiomyopathy resolved. So this is the big conundrum for me in my practice. I thought I was a smart guy because I only put in 6 metal on metals as a surgeon. And I've tracked all those patients down and rectified their problems. I never put in the rejuvenate, but I've rectified a lot of the rejuvenate. So I kind of consider myself to be the savior for those patients. But as a surgeon, I have implanted about 1,000 hips with modular Chrome-Cobalt heads. And what I've learned over the past year is my own patients that I have placed these hips in are now presenting to me with both the problems at the hip from the corrosive debris and with the systemic issues. It's the same story all over again. These patients are very similar to the rejuvenate series because the cobalt is produced by corrosion. The difference is they're not getting into trouble at 3 or 4 or 5 years after surgery, and the problems are usually not recognized until several years later. These patients are getting into trouble at 6, 7, 8 years after surgery, and we're not recognizing the problems until a decade after implantation. And when you deal with this longer latency, the more difficult it is for the providers to relate the patient's problem to the fact that they've had a hip replacement. And this is one of my patients. I didn't call this guy into the office. He presented back to me because of onset of problems at the hip a decade after I had put this hip in. It's a non-recalled implant. Nobody believes that these hips have a problem. Cobalt level is elevated 6 parts per billion. He's probably had a long period of exposure. He's a very sharp guy, but when we did quantitative neurocognitive testing, the clinical psychologist felt he ought not drive, both because of motor coordination issues and poor reaction time, but also because of significant deficits in judgment and higher cognitive function. So I'm in the point now where I believe I'm responsible for the about 1,000 patients I put these implants in, and I'm trying to construct a means in my practice to bring these patients back in for review. Again, my emphasis has been on the systemic issues because I think the problem has not been well recognized. The problem is recognized in the orthopedic community as far as the problems that occur at the hip. That said, we're only picking up these patients when they come into our office in trouble. These patients are not being systematically screened and brought in for review. And this is a problem because if you wait until patients have symptoms at the hip, a lot of times they have irreparable tissue damage around the hip that makes revision surgery and remediation difficult. As far as the systemic symptoms, think of this as accelerated aging, a toxic progeria. These patients, cobalt mucks with the mitochondria, and it tends to affect highly metabolic cells, which explains the neurologic presentation, explains the cardiac presentation. I enlisted a couple of medical students and an epidemiologist to review all the case reports in the literature. We came up with 25 then. I think we're up to about 50 now. You have to understand, if it's a case report in the literature, you're dealing with an extreme case. This is the far right-hand foot of a skewed distribution curve. For every case report in the literature, there's probably 10,000 patients that have mild or moderate cobaltism related to their implant. And that's the focus of my work now, is recognizing the subclinical, the mild, and the moderate cases of cobaltism, so these patients can be remediated before they progress to the more severe forms. This isn't difficult to monitor patients. Cobalt is concentrated in the urine. There's no individual in this room that has a cobalt level in their urine greater than 1 part per billion. I believe any patient with an at-risk hip, which is the majority of patients in the United States that have had a hip replaced in the past 20 years, that a urine cobalt on an annual basis is indicated. Well, why do it annually if somebody is not peeing cobalt? It's because this problem has a significant latency before the corrosion develops. So though a patient may not have had the problem a year ago, he may develop it within a period of a year. Certainly there's many risk factors that we have not yet defined. Certainly we're recognizing that some implants are at higher risk than others, and we're really not certain that the problem is just limited to the hip. So as far as those in the audience who are primary care providers, when you have your aging patient come to you, or even some that aren't so old, who have new issues, you think you're dealing, about half of the patients that I've been exposed to have been treated for depression, and the onset of their cobalt encephalopathy is commonly interpreted by the primary provider to be depression. And they're treated with antidepressants and their depression improves, but it doesn't improve their cognitive decline, which tends to progress. So that's a confounding factor. But this is just a list. You can refer to this in the handout as far as what blood cobalts mean in terms of the described pathophysiology that we've seen to date. When I have a patient that's peeing cobalt, it's not very common that an orthopedic surgeon sits with a patient in a room for 30 minutes and does a comprehensive review of systems. That's what I do when I have a patient peeing cobalt. And if they start ringing the bells in the cardiac and neurologic and psychosocial functioning positives that are consistent with cobalt encephalopathy, I send those patients for the FDG PET brain scan. And I'm to the point of confidence now with that imaging that it is weighing into our decision about whether or not to revise the hip. How did we get into this pickle? We had very, very safe implants in the 1970s. We have a regulatory process in the United States that allows changes to these devices to be made helter-skelter without any evidence that the changes are improving the operation. Not only do these changes increase the chance that a patient will need premature revision surgery, it also drives industry, which allows these implants to become more complicated but also more expensive. So it increases the price of the operation. And this is just an example of how complex these implants have been made over time. If you look at the very successful Charnley arthroplasty of the 1970s, which is still in common use in many countries that have more of a public evidence-based model for what implants a surgeon is allowed to use, it is remarkable that of the hundreds of changes made to hip replacement over the past 40 years, probably greater than 99% have made the operation worse rather than better. And they certainly made the operation much more expensive because they've not only increased the cost of the primary operation, they've also greatly increased the chance that the patient will need even more expensive revision surgery prematurely compared to the established safe technology. This is just an example of how frequently these hips need to be revised comparative to the Charnley arthroplasty of the 1970s. And the 8 patients that I described earlier that have the abnormal PET brain scan are emblematic of who pays the bill. And the bill is being paid by the public one way or the other. And the cost is going to be extreme as an aggregate. From a regulatory standpoint, I don't have much hope. Political pressures, with our political system basically being bought by industry with Citizens United decision, and this feeling in the country that industry is over-regulated in medicine. The pending legislation would make these changes only easier for the companies because they're diminishing even further the level of evidence of safety for a new medical device. My opinion why this happened in the United States is just the commercial model for medicine that we have in the United States. New and sexy markets really well to surgeons and to the public. If I have a patient that's convinced through the internet, through the initially good experience of their friends that the kryptonite hip put through the anus is the way to go, I can spend my entire day in the office talking to that patient and I cannot talk them out of it. They are going to get a kryptonite hip put through the anus by one of my colleagues down the street. It is just amazing, a patient does well in the short term, attributes their success, which has nothing to do, most of these patients have done well despite the technology. They would have done equally as well with proven technology. But once, the guy tells all his other buddies at the hockey team that he's back on the ice 1 week earlier because he had the hip done through his navel, all his buddies are going to rush to have it done that way. Even though once we get, joint registry data, which shows that these patients are having a much higher frequency of severe early complications and a much higher rate of revision within the first 10 years, by the time we have that data, 90% of the hips in the country are going to be put in through the navel and are going to be made out of kryptonite. And then we're dealing with the fallout later. Monty Python and the Holy Grail. Who knows that movie in this room? Because I draw a blank when I give these slides. But it's like orthopedic surgeons. We had the Grail in like 1970 and we lost it. What is the Holy Grail of a total hip? You want something that's safe. You want something that cures a patient's pain, which is the primary reason that they came to the surgeon in the first place. You want a durable result. You want those patients to be able to go back to activity. And we had that quite consistently in the mid-1970s. So what happened? Well, we made all these changes to the devices, the problems of which don't surface till 5 or 10 years after the initial operation. There's great popularity of the new devices. So in the United States, the whole market drifts to the new devices. And then suddenly, well into the story and the quest, the killer white bunny jumps out and unexpectedly starts decapitating the knights. And this is the story of Cobalt. You're dealing with something that was not expected. When I was sold my ASR hip, one of the design surgeons came to Alaska, and I was pretty knowledgeable and interested in joint replacement even before my problems. And I said, Tom, I read the literature and I understand patients with a well-functioning metal-on-metal hip have a blood cobalt level that's twice that's allowed in industry. And he looked at me and said, Steve, how can something measured in parts per billion possibly hurt a human? So how do we fight this? I don't think we're going to solve this by regulation. I think we need to apply the holy hand grenade of empirical science. And it's going to have to be the providers that provide the standard for this. We're going to have to fight an uphill battle through the literature. Dr. Bridges, my radiologic colleague, calls peer review peer censorship. And you have to understand, my experience, which we wrote up in another paper, is if you are the outlier that is trying to expose these problems in the orthopedic, I think in all realms of medicine, but particularly so in orthopedic surgery, your peers, your betters that are doing the peer review for the journals, those individuals are likely on the consultant panels of the people who make the implants. The speakers at our convention are almost always on the consultant panels of the individuals who make the implants. Our officers in the American Academy of Orthopedic Surgeons, same story. When I took exception with the fact that I had 11 presentations to the Academy of Orthopedic Surgeons turned down, I researched the affiliation of the committee that made those decisions. 75% of the surgeons on that panel worked from one company that had a huge stake in metal-on-metal hips. So I think it's going to take organizations like HealthWatch USA. I think it's going to take some real proactive press to bring this to light in order to affect change, because I don't think we're going to do it through regular channels. I certainly don't think we can do it politically. This is going to be extraordinarily costly. This is going to be a public cost. I think the hip metallosis issues are going to cost the United States on the order of $10 billion a year, not chump change. A shout out to some very inexpensive research efforts that are helping us understand this program, this problem. I've had a collaborative relationship with Dartmouth Biomedical Engineering Center. I send them all the failed hips I take out of people, and they have been on the point of the spear in terms of defining both the wear issues with metal-on-metal implants. The problems we had with polyethylenes 10 years ago has been resolved as a result of work from this lab, and they are now on the forefront of understanding the corrosion problems. So that's my talk.